So it's very easy to say active is better than passive. I mean, it's you look at every blog says it. You Google that and you'll get 150 people saying, "Oh, we know, we're confident that an active approach leads to better outcomes than a passive approach." But the literature is mixed on that. And I think those folks that actually read the literature might be surprised to find that statement has a lot of, it just doesn't have a lot to support it.
Hi and welcome everybody to episode 47 of the Physiotutors podcast. I'm Kai Siegel and today we will talk about the demonization of and the future of manual therapy with Chad Cook. Chad is a physiotherapist, a professor at Duke University and a clinical researcher who has published over 330 peer-reviewed papers. One of the last papers he has published is called The Demonization of Manual Therapy, where he evaluated common critique on manual therapy based on the current literature. Before we start, we do have an announcement to make. You might be wondering why you're listening to a podcast host with a German accent. Our former podcast host, Sunny Sandhu, has left us to work in a clinic again full-time after hosting our podcast for 46 episodes. We wish him all the best, and his British accent will be dearly missed. So, Chad, welcome to the podcast. It's an honor to have you.
Kai, it's an honor to be here, and if I may say so, I appreciate everything you all do. I know my students love your work, and keep it up. I think it's very helpful.
Thanks a lot. Great to hear. I'd say let's jump right in. So before we talk about manual therapy in detail, let's maybe first define what your definition is of manual therapy.
Well, I think that's a good place to start. My gut tells me that if you put 10 manual therapists in a room and ask them to create a definition, you'd get 10 different definitions. And even mine has changed, I think, over the years. I would say that it's the closest to the National Institutes of Health definition, which they call force-based manipulations. That's their term for manual therapy. It would be passive external force to the body with therapeutic intent. And what they'll include in that are things such as manipulation, mobilization, acupressure, soft tissue mobilization. They also include acupuncture and needling. I don't think those last two are really manual therapies, but that's my opinion.
I'll not mute the mic. All right. Okay. And why do you think the pendulum has swung so much into the opposite direction? Why is it that there's so much critique on manual therapy nowadays?
I think first I was surprised. I've been talking about this so much now. I've created my own theories. I think some of the reason is if you look at some of the philosophies on manual therapy, they're pretty outlandish. And there are a lot of really dated philosophical constructs around manual therapy. Some stuff which is really odd, mystical, and weird. So I think as people migrate toward evidence-based practice, there's probably a lot of internal conflict in the way that they feel about certain things and what they're hearing from manual therapists, and that probably doesn't sit well with them. I've also think that there's a good possibility that they've had bad experiences with manual therapists. I think there's been elitism in the past. A lot of manual therapists are highly trained and were somewhat arrogant. I certainly experienced that when I went through my training in the 90s, and it turned me off toward manual therapy quite a bit. So I think that's part of it too. I also think it has to do with probably the patient population they see. If they're dealing with individuals who have high levels of pain behaviors or high impact chronic pain, a really chronic pain population, I don't necessarily think manual therapy is the best approach with that population. So if that's their population, maybe they're not seeing any value if they've used manual therapy in the clinic. And the last one, I think it's been very popular on social media. It's helped elevate selected social media influencers' positions by being anti-manual therapy, and it's created a lot of likes and clicks and whatnot. So I think it's probably all of those things.
I think maybe the pendulum has also swung in the direction of pain science, and pain science maybe doesn't fit perfectly with the original theory of manual therapy. And if we move on and we look at what manual therapy does, I mean, it's first of all, it's a pain modulator, but some people on social media especially suggest that, for example, ice packs or just taking a walk or exercise are evenly effective ways to modulate pain. So what, in your opinion, makes manual therapy different as a pain modulator?
Well, I guess there are two things when I think about that. First, the mechanisms are different. So if you look at this with more of a reductionist viewpoint of what actually happens physiologically, manual therapy is fairly well studied, and we do know that it does lead to physiological changes in the body that aren't necessarily the same as a cold pack or going for a walk. So there's a difference there. Whether that leads to the reason why we see changes in the clinic, we don't know that yet. That needs to be further explored. We do know in the clinical effectiveness research that manual therapy tends to be as good as or better than comparative interventions. And that includes the whole gamut of what we do as physios, and that would be exercise, CBT, a pain science-oriented educational approach. It doesn't matter. Manual therapy stacks right up there with it. So I would argue that one of the reasons why we see benefit with manual therapy clinically is because the patient is actually pursuing care. It seems to be the thing that makes the biggest difference is when the patient actually takes that active step to pursue care, it makes a difference in their overall outcome, regardless of what they receive. So just telling somebody to put an ice pack on it or going out and take a walk, it may not have the same contextual benefit as actually actively pursuing care. That said, manual therapy and other interventions might be the choice in that particular case. I think it's going to depend on the patient.
Okay, thank you for your answer. And if we look at manual therapy a bit more in detail, what we personally learned during PT school and also during our masters in manual therapy is that you assess a certain body part on hypomobility, especially, and in the spine you would then call this assessment technique passive physiological intervertebral movements, or PIVMs. And do you think this hypomobility assessment still has a place?
Not in the traditional way that we learned it. I'm aware of the literature that has actually looked at our ability to reliably do this across clinicians, but also literature that looks at the validity of this in comparison to an external device that actually assesses the stiffness of that particular area. And we're just not very accurate or valid on either one of those. I have stopped using PIVMs in the low back and the thoracic region, primarily because I don't think it gives me a lot of value and in a clinical judgment sense. In the cervical spine, I think there's still value because you can assess movement with this and whether that movement is related to the pain of the patient. So I don't use it to try to identify a guilty segment or anything like that. I use it to determine whether or not it may be a valid treatment option for that particular patient and what happens when you incorporate movement into the neck.
Okay, maybe as a follow-up question, do you think it's necessary to be specific with your mobilizations and manipulations then?
Yeah, the literature suggests it doesn't matter. And Casper Nim's recent systematic review that he published, I believe it was earlier this year, actually shows that. We were part of a 2016 study where we compared a specific approach for patients with chronic low back pain versus a non-specific approach, and we found no differences outside of the grok, and we followed people out for 6 months. I haven't seen a study yet that has actually suggested that a specific approach is going to be better than a non-specific approach. We published an editorial earlier this year in JMMT, and we actually have identified 2 studies where a non-specific approach gave a better outcome than a specific approach. So, no, I don't think you need to be specific. I think whatever is happening, the magic that happens with the manual therapy, the mechanisms that occur, are probably going to occur whether you're specific to the segment or not. I think most of the interventions we use are not specific to one joint anyway, despite being taught that, I think, in most of the traditional manual therapy education.
Okay, great. And if we say we are not able to determine a hypomobile segment by PIVM assessment, and if we also say it's not necessarily better to be specific with our region specific with our manipulations and mobilizations, how do you then select or identify patients that respond favorably to manual therapy? Like, which are the factors that influence your decision to provide some form of manual therapy or not for a particular patient?
Yeah, that's a great question. And I'm going to muddy it up just by saying, well, it depends on the patient. But there are a lot of factors that go into my decision making regarding whether I would use manual therapy with a patient. The first one is, what is their pain mechanism? So if this is an individual that is dominant nociplastic pain, then I'm already thinking I'm probably not going to use a manual therapy approach with this patient. There's going to be a lot different of an approach to intervene in this case. If it's dominant nociceptive pain and during the assessment, the movements of that assessment seem to pain modulate, that this person may actually benefit from that, whether it was through active movement or passive movement, then to me that is an open door for a possibility. We know patient expectations are very strong predictors of a potential outcome, and this is in the conservative care literature, it's in the surgical literature. So matching patient expectations to interventions is something that actually has validity. So if a person expects to see benefit with manual therapy and you find positive outcomes in your assessment where movement seems to modulate their pain, then there's absolutely no reason not to in that particular case. We have identified prognostic findings in the clinical examination that we've published previously, and that's where a PA, if you use a UPA or a CPA and you get about a 30% pain modulatory outcome from that in patients with neck and low back pain, it was very prognostic for a positive outcome and in the short and long term, especially if that carried over for the next visit. That's another thing that is a highlighter to me that the patient may be a candidate for manual therapy. And lastly, there's a statement we say in the United States that a lawyer never asks a question that they don't know the answer to already. And I think a manual therapist needs to be the same way. You should know exactly what to expect with that patient. There should be no experimentation. And if you're not sure what the outcome is going to be, then they may not be the candidate. It should really be evident, I think, of what the outcome is likely to be.
Yeah, I think personally, one factor that I take into account is positive response to earlier manipulation or mobilization. So I think that also plays into patient expectation. That's
totally agree.
Yeah. Okay, and if we then look at skill required for manual therapy, I mean, there's a lot of continuing education for manual therapy, and there's a lot of courses where people pay a lot of money for it. Do you think that's justified?
Yeah, that's a great question. I think there's going to be an overhaul on the way that manual therapy is educated, and I think that overhaul is due. And I think that originally, as you mentioned, manual therapy was driven by the marketing aspect of it. You need 6 courses to achieve competency. You need these 10 courses to achieve ability. I think it was driven by that, and I think it was driven by pioneers that really believed the philosophies and the theories that they put forth in that educational process. So I don't think they were doing anything nefarious. I just think that they truly believe that. And now that science is caught up with manual therapy, we recognize that maybe that's not needed. when I think of the skill needed in manual therapy, there has to be some handling skills involved. You're not going to just wake up on a Monday morning and learn how to manipulate with the patient that's in front of you. I think there's, just for safety reasons and for patient handling and confidence reasons, there needs to be a base level of skill in that area. I think some of the more valuable skills are associated with how you communicate what you're doing with the patient, and so the patient understands what the role of manual therapy is in their comprehensive rehab program. I'm not sure all manual therapists communicate that correctly. And then secondly, a recognition of what a positive outcome looks like with manual therapy. In other words, how is that patient responding? Are they responding the right way? I think a good manual therapist recognizes that. Those things need to be learned in an educational program, and it's probably going to require a reboot on the training process for manual therapy.
Okay, great. Yeah, I think if I take our own masters, we learned a lot of manipulation techniques for the whole body. And I mean, they were certainly valuable, but I think personally, and Andreas will agree, what we learned mostly was the whole framework of clinical reasoning through our 3 years masters. So most students will probably say that the biggest takeaway wasn't that the manipulation and mobilization techniques, but more the clinical reasoning that we got in this 3-year process. If we look at effectiveness of manual therapy, so some studies show that manual therapy is not more effective than placebo, and that's a critique a lot of people have. Do you think that maybe it's time to embrace the placebo effect of manual therapy, or possibly try to enhance it?
So I'm going to unpack that a little bit, because I just spoke at a conference about the sham studies that have been published. And this is not just me talking. There's actually been several studies that have, several systematic reviews that have basically said that the sham studies for manual therapy are low quality, and the takeaway from those probably isn't very valuable. In fact, there's a BMJ Open paper from 21 by Carolina Lavazza that basically said the grade level, the confidence level was low and very low. So very low certainty that this actually represents clinical practice at all. So I would first phrase my statement as, I don't believe the sham studies that have been performed right now accurately tell us a true comparison between a manual therapy approach and sham. Another thing I want to report on those, 46% of the studies on sham involved one technique performed one time. And then they look for a difference in outcome with that. And I don't expect to see any benefit from that. And one time is not typically going to make a difference with anything. And we see that with the exercise studies too. One visit of exercise doesn't have a pain modulatory approach. There's a review that came out this year on that. With respect to the placebo effect, should we embrace that? I like to call that the contextual effect, because placebo effect falls within the contextual effect, and the contextual effect will incorporate other elements too, such as that relationship between the clinician and the patient, meeting patient expectations, the environment that you're in, all of the elements that seem to enhance or reduce a particular outcome. So whether we should embrace it or not, absolutely. I think that's one of the reasons we see some clinicians have higher levels of outcomes than others, even though they're using similar interventions, is because they've created a context in which the patient feels that they are benefiting the most. We have many interventions out there that have high levels of contextual effects. Surgery has a high level of a contextual effect. Cognitive behavioral therapy lives off the contextual effect. So these elements are all areas in which I think we should embrace that.
Yeah. Personally, I find it quite a challenge to, try to enhance those effects. I think if you turn manual therapy into quite a show, and you certainly believe that it will work, this probably has a positive effect on the patient. But at the same time, I'm pretty critical towards manual therapy. And if I tell a patient that it probably has a short-term effect, am I not kind of lowering my placebo effect by telling that to the patient? That's what I'm wondering.
I think you run the risk of reducing the placebo effect, of telling them that it has a short-term effect. Physiologically, it has a short-term effect. We know that in the clinical effectiveness studies that when manual therapy is combined with other active interventions, that the outcome tends to be as good as or better than comparative interventions. I usually frame it around that. I think another way of framing it, so to speak, because you're right, our studies in the past have actually shown that the therapist's thoughts, their beliefs, can be imparted on the patient, and it actually influences the equipoise of that particular situation. So it can easily influence that patient. If you go in thinking it's not going to work, then the patient's they're going to extract that from you. I think being positive about the intervention, indicating that you feel confident that in their particular case, this is likely going to be something that's going to be beneficial. It's going to function as a segue toward being able to do more activities. I will say this, I don't just do manual therapy or just do exercise. It's not when I go out to dinner, I eat and I drink. I do both. So there's no reason that you have to do one or the other. They're not mutually exclusive. So it's perfectly okay to say this is packaged within this care process that we're working on, and I think it's going to be useful in your particular case.
Okay, great. Another question, that the probably biggest critique on manual therapy is that it creates patient reliance and dependency. What does the literature say about that?
Yeah, I haven't found any studies that have actually shown that it creates reliance or dependency. I've seen a lot of literature on opioids or alcoholism, things like that. I haven't seen anything like that on manual therapy. I get asked that question all the time. And I would say every conference I'm at, every course I teach, every whatever, I get asked that question. And I think the reason is because every clinician has experienced a situation in which they've worked with a patient that had 100 visits from a chiropractor or somebody who did the same thing. They did manual therapy and there was no benefit, but they kept seeing them and seeing them. And that's very concerning. To me, it has less to do with the treatment provided and more to do with how they were managed. I think that's a clinician issue. I think that's a patient management issue. Certainly, any form of treatment when overused, if you just receive pain neuroscience education each visit and you don't see a benefit from that, that's a management issue. It's not pain neuroscience education. So that's the way I see it. Certainly, some individuals are going to be more likely to seek out passive care, and we see that in the literature. Their coping mechanisms why there tends to be more passive coping individuals who pursue chiropractors than they do physical therapists. We know that in the literature. So certainly that's going to take a conversation with that patient to get them out of that mindset.
Okay, so it's maybe more for selection bias issue as well, that if people who provide manual therapy see more patients who are prone to passive treatments or to dependency on a patient than people who seek active treatments who want to rather manage their condition themselves. So maybe that's also an issue.
I think we're homogenizing though as professions, don't you? I'm on a grant right now that has a number of different professionals on it, and they all use manual therapy. And when we have conversations, everybody is kind of migrating to a common ground, and people are less passively prone than what they were before. So I'm optimistic that people are seeing the value of using manual therapy the right way, which I would argue is probably more effective if used early, maybe 4 or 5 visits. You'll max out, I think, after that for any benefit that you get, and certainly never as an intervention by itself. It should be combined with other interventions.
Yeah. You kind of already answered my next question, because I was going to ask, regardless of the evidence, do you think that passive treatments in general could potentially send out the wrong message that we as therapists are the fixers and that pain is something that always needs to be reduced.
So I'm going to just add on a little bit to that. I actually think pain is more complex than just being able to frame it in a way that you answer, that you can answer it one way. I know that there are different pain mechanisms, so people experience pain very differently. I know that there are some individuals that you will see in which you absolutely should not target reducing their pain as the primary objective because you're probably not going to be successful with that. In those individuals, pain intensity may not be your best objective, that maybe looking at areas such as pain interference or disability might be a better option. So it really depends on the patient. Those individuals that treat nothing but high levels of pain behaviors, high impact chronic pain, they're probably not going to use manual therapy a lot, as I mentioned earlier. But if you're just seeing your garden variety person that's coming in that maybe strained their neck or tweaked their back or something like that, I think those clinicians are more likely to see benefits from manual therapy when used correctly. And yeah, so I think it depends on the patient and it depends on their pain mechanisms.
Yeah, fully agree. And if we look at value-based care, because that's another demonization that manual therapy doesn't fit into value-based care. If we look at efficacy, that is one way to measure value-based care, but costs and patient satisfaction are different outcome measures. So my question is manual therapy cost effective? And the follow-up question or the second question is, does it also lead to a higher patient satisfaction?
Yeah, so I'll target the cost effectiveness one first. And so I know of 12 studies that have actually looked at manual therapy versus a comparison group for cost effectiveness. It tends to be as effective as a typical, as a comparative physiotherapy intervention. So as effective as exercise, as effective as an active approach or whatever. It is more cost effective than usual care or any type of medical care, as it should be, because those tend to be more costly, more invasive, more long-term. So I'm not surprised that it's in those studies that it's actually more cost effective, and it has been demonstrated. And by the way, we do have that information on our CMET website for anybody who wants to look at it, but there are several studies that have actually looked at that. I do know of one study that has looked at patient experience and whether or not people were more happy with an active approach versus a passive approach. And it's partly because I've got a lecture coming up in February where we actually talk about passive versus active care. And that's a big thing with value-based care. They say all passive interventions are low value, and that's just not what the literature suggests, which is why I think we need to revise this definition of value-based care. And one of the reasons we published a paper on it a couple years ago that suggested a different definition. But it did show that if you do only active-based interventions, that the satisfaction or the patient experience was lower in that particular group. So that's something to consider. That's only one study, though, so I'm not sure. I think how you frame the treatment experience for the patient, whether you use manual therapy or not, probably isn't going to matter. Yep. I think it's going to be more about that, about the value the patient feels during that interaction.
Yeah. Personally, I think a lot of patients still also have the expectation that some sort of passive treatment is or will be applied. I mean, and I think if you have a patient like this in front of you and you only expect active or you only provide active options for this patient, I think, that patient experience or the patient satisfaction will be lower in those cases.
Kai, I've talked to a number of clinicians who own their own practice and throughout Europe and the United States, and they will tell you that they have to perform some form of passive intervention just to show value to that patient so they can keep them coming through the door, so that they can see that patient. And we do know that it does make a difference if the patient is seen, if they're actively pursuing care. It makes a difference versus usual care or no care. That makes a difference. So if that's what they need, those clinicians, if that's what they need to be able to see that patient, then I understand why they do it.
Yeah, I think as a younger physio, I was quite inflexible and strict sometimes with providing passive treatments. But I mean, my experience was also that if a patient is really expecting passive treatment or manipulations and mobilizations, and you don't at least give them a good explanation or give a little bit of passive treatment, those patients are just going to seek another healthcare professional. So I think now I'm less strict personally. So I try to have some passive treatment, but slowly, gradually move them towards a more active approach, in order at least to create some buy-in from the patient.
Kai, there's a really good paper by his name's Adam Lutz, and they published the work last year in 21. And what they did is they built clinical profiles of the most effective clinicians in this very large organization in the United States. And they had over 100,000 individuals. And the most effective clinical profile that led to the best outcomes were those individuals who used manual therapy, but also adjusted their treatment process for that patient in front of them. And the worst clinicians were the ones who adopted a strict, inflexible treatment approach that didn't change throughout the care process of that patient. And to me, that's real world evidence that is fairly remarkable, that suggests you have to adapt to that patient in front of you. And we have all seen that, right? Patients, they wax and they wane in where they are. And Lutz's work basically says the best clinicians are the adaptive clinicians.
Yeah, I like how you always have some kind of study backing up what you explain. Like it's just my experience, but you can back it up with papers. Actually, that's great. And if we move on and to the next question, like if you could change the way manual therapy is taught and practiced nowadays, which parts, in your opinion, should be abandoned, and which parts should be maybe kept or even further exploited?
Yeah, that's a great question. So we talked a little bit about training earlier. I do think training needs to be modified. Again, the focus more on clinical reasoning and what to expect, what accounts as a positive outcome from the patient, how to communicate that well with the patient, how to incorporate that with other interventions, whether you want to package it with pain neuroscience. I don't think the two are that different. I think they actually can be gelled together, and certainly packaged within an active program as an adjunct to that active program. So that piece needs to be baked in there. I'm an incredibly polite person, but I do think we need to find a way to divorce ourselves from some of these very old, outdated biomechanical theories and philosophies. Many of these were created over a century ago. Some people still focus on these. I still hear some clinicians quoting work that was done 60 years ago that has been refuted in the evidence quite clearly. I think those need to be extricated from what we do. So a removal of that. I think there needs to be a better underlying understanding of what the mechanisms are with manual therapy, so that if someone asks us what is actually happening here, we can have a coherent conversation with someone. Well, this is what is happening. This is what we know. Here's what we're theorizing that it does for a clinical outcome. I think it's a big stretch right now to think that these mechanisms are the reason we see clinical outcomes with manual therapy. I don't think we've studied that well enough yet, but certainly that needs to be built into it as well. And I think there needs to be as much in the training about modernizing how manual therapy is baked into care, and helping revolutionize how this is presented moving forward, and being an ambassador for more of a modern approach to manual therapy. That should be part of the training as well.
Yeah. Don't you think that if you look at social media and what is shown on social media, by a lot of those gurus and who based the whole manual therapy applications on false narrative. Don't you think that if those people, or if we have a better narrative and we stop the guruism, that I think the critique on manual therapy will be way less? Because I think this is where a lot of critique is coming from.
I do. And in fact, when I've had a sit down with a lot of anti-manual therapists, I think their biggest beef has been the false narratives. And if there was a way that that could be changed, I think it would help quite a bit. You know, most of those individuals that created those narratives are dead now, but we're still incorporating it into clinical practice and how we discuss things moving forward. It's just surprising to me. I think it's okay to change theory over time. In fact, I think you almost have to do it. I think it's imperative that we do that. So absolutely, if that piece was fixed, I think a lot of the anti-manual therapyism would certainly decrease.
Yeah, that's maybe the perfect segue for our last question, because we talked about what should be abandoned and what could maybe be even further exploited. What do you think the future of manual therapy will be if you think ahead 5, 10, 20 years from now?
I'll start with I'm not sure. Because I've seen a huge change in thought processes around manual therapy, and I've seen a lot of physical therapists go to, you know, a hands-off approach, which I don't think is the best approach to go. I think you're losing out on something that has a lot of therapeutic value. I think it's definitely going to move toward more of an evidence-based approach. I think there are going to be more limitations, a lower ceiling on the expectations on what it actually does. I think we're probably going to get a better understanding of where it fits within an appropriate treatment approach. But I also think we're going to get the same information from our other interventions too. I think we'll realize there are ceilings on other conservative interventions. So I think it's going to march in parallel with a lot of the things that we know about physical therapy care.
Yeah, I like that answer. I think also, like, if you look at young physiotherapists who are moving towards an only active approach, maybe they don't see yet that also exercise has its limitations. And I mean, just because it's an active approach, we're maybe not that critical towards exercise therapy.
Can I just throw one more thing
Sure.
on that? So it's very easy to say active is better than passive. I mean, you look at every blog says it. You Google that and you'll get, you know, 150 people saying, "Oh, we know, we're confident that an active approach leads to better outcomes than a passive approach." But Kai, the literature is mixed on that. And I think those folks that actually read the literature might be surprised to find that statement has a lot of, it just doesn't have a lot to support it. I think Jill Hayden's recent paper, Systematic Review for Exercises versus Comparators for Low Back Pain, it found that exercise has basically the same effect as manual therapy. Comparatively, they have the same outcome in the randomized controlled trials that have been compared. That probably will surprise a lot of people. The origin of this, you know, active is way better than passive. It's not built on a really firm foundation. If you ask me, I would say absolutely. If I'm left with one intervention, it's going to be active. Active theoretically should lead to a behavioral change in the patient. We don't see that. Patients typically stop doing exercise as soon as their interventions stop. But in theory, it's strong. That's why people adopt it. And the evidence, it's not that strong yet.
Okay, I think those are nice last words for our podcast that I would like to conclude. So I'd like to finish off by saying, Chad, it was a pleasure to talk to you. And where can people find you?
So if you're interested in getting an unbiased approach that doesn't include misinformation on manual therapy, then look us up on the Duke Center of Excellence for Manual and Manipulative Therapy. And then I'm also on Twitter, and that's at Chad Cook PT, at Chad Cook PT.
All right, Chad, thank you so much. And for all of the listeners out there, thank you very much for tuning in. And let us know what you think of our new podcast format. And make sure to sign up for our free Physiotutors membership on physiotutors.com to download a transcript of this episode and to get access to more useful physio content. If you're listening on Spotify, click on follow. If you're listening on Apple Podcast, click the plus icon. And if you really enjoy the podcast, consider writing a review. This was Kai for Physiotutors, and I'll talk to you in the next episode. Bye.